Now we can move to our next speaker, and our next speaker is John Bolger, who will discuss about neglected cataract with dense anterior capsule fibrosis.
Hello, we're going to look now at a case of a neglected cataract and how a strategic approach to such a situation will be very helpful. This was a lady who was fairly elderly, had no English, was blind in this eye, but had had successful cataract surgery already by me in the other eye, and this gave her some enthusiasm to proceed with surgery in the left eye. Now, as you can see on the zoom in there, this was her fully dilated, and is a very dense cataract with a calcified and opaque anterior capsule. So if you can see there's no history of any ocular pathology. We had to do immersion ultrasound biometry. There was absolutely no view of the posterior pole, and she had a calcified anterior capsule and a luminescent lens. So no reliable prognosis was possible, but she was keen to proceed. So we decided that we would go ahead with her wishes to try and restore some vision to the left eye. Now, in any case, it's always important to have a definitive strategy, whether it's a simple case or whether it's a very complex case like this one. So in this scenario, I decided I would proceed with a local anesthetic, topical, then intracameral. I was going to use a 1.8 limbal incision. I normally use a scleral tunnel, but I thought I'd move to the limbus in case I need to convert to an extra cap. I'm going to use a pupil expander rather than hooks or stretching, and I would stay in the capsule because it was probably going to be helpful in any event. I also decided that I would use the Clearty radio frequency probe for the capsular excess, which I find very useful for these sort of cases. Now, because the nucleus is quite dense and hard, I was going to use 100% continuous, not pulsed, phaco power, but pause after each downstroke to ensure that the tip would cool and reduce the risk of a phaco burn. In this case, for me personally, it's very important that I go deep centrally to the posterior pole before attempting to crack. I find that if I go really deep at the center, the lens tends to fall apart much more easily. And then, of course, once the lens was cracked, I determined that I would keep the phaco tip in the safe zone, that is the center of the pupil in the plane of the iris. And I would ensure complete separation of each segment before attempting to emulsify it. I also had a whole load of backup viscoelastics and IOLs, including an iris clip. So this is the surgery itself. This is her maximally dilated, and with topical anesthetic. I've made the incision, and you can see I'm trying to see if the pupil will enlarge at all with viscoelastic or any sort of stretching, but clearly it's absolutely rigid. The iris is completely fixed. So looking in there, injecting viscoelastic, no evidence of any movement at all. So I thought, okay, well, let's go to keep with the plan, keep with the strategy, and insert this pupil expander. So you can see there, it's important to get the first leading clips under the inferior portion of the pupil margin, and rather than pushing it in from above, I let it settle like so, and then manipulated the two other segments into the pupil margin to give me access to the anterior capsule. And this is all under quite a heavy viscoelastic, such as Helon 5 or GV. So now I've got the pupil expander in, and you can see the extent of the cataract. I put in the vision blue in this case to stay in the capsule to try and help me. And now with the Clearty radio frequency probe, this probe comes from a company called Oertli in Switzerland, and it produces a very pinpoint area of heat just at the tip that allows cutting of the capsule in a very controlled manner. And you can see there, as I move the tip around the capsule, it releases gas, and that level of bubbles indicates to me that it's just cutting just right. That's exactly the sort of bubbles I like to see. But it cuts around in a circle, and you can see that I move very cautiously across under the incision, and make sure I meet up with no gaps in the middle. Back in with viscoelastic, and I'm now checking that I have actually cut all the way through because of the fibrotic capsule. And you can see it's still tethered there infratemporally. But you can see with the capsule forceps, I'm able to tease away the sort of normal capsule, if you can call it that, very gently, because clearly I don't want to run this capsulorhexis out to the periphery. That would make things very, very difficult. You can see now as I grab the fibrotic part, it just gives way and releasing itself from the rest of the capsule. But as I try to remove it, it's clear that the capsule is still attached at that segment there infratemporally. Pulling it will only just rip the capsule or rip the zonule. The great advantage of the clotty is I can go back in with it and recut it. So I can see that I've gone back over that area again with the cutting frequency, and you can see it's beginning to give way. So again, it's not completely free, so I'm cutting it again and again until I've got through this dense fibrotic calcified anterior capsule. Last pass again to the thickest part, and eventually it comes clear. I then go back in with the forceps to see if I can remove it through the main incision, and it does come out, and not in one go, but in two. Now the phaco. So here I'm making sure I get deep into the lens through the posterior cortex into the back of the lens, using very high power, very high energy levels, because I don't want to put any stress on the zonule, and I want this to cut and cut. But I'm taking it very slow, and I give plenty of rest between the downstroke, which is foot position 3 in phaco mode, and the upstroke. Now you can see I've gone all the way through, and I'm now making the first crack by there. And I want to be sure that the lens will separate completely. I really want that segment completely separated, otherwise it won't come into the tip. Now, engaging foot position 2, bringing the quadrant into the safe zone, and then foot position 3 to emulsify. And you can see very slowly the lens beginning to disintegrate. So that free portion in the middle is, willing to come forward, and I'm not having to chase after it. I can stay in the safe zone with the tip of the phaco probe. And again, it's a question of very gently bringing the pieces to the safe zone and making sure that when I crack them, they do actually completely separate, because otherwise they just give me a lot of difficulty in not coming into the safe zone, and then forcing me out into the equator, which is where trouble happens. So now I've engaged this piece again in foot position 2 and holding it with the vacuum, make sure that I get that quadrant separated, and then bring it into the central portion. Another sub chop to just make it a little bit easier, and then keeping everything in the safe zone, foot on the floor, very high very high energy levels, very high aspiration rate, about 35 mils a minute, a vacuum of about 500 at this stage, not during the sculpting phase, obviously. So now back into foot position 1, making sure the tip is cooling down, and again, chopping away the next quadrant or segment, bringing it into the middle, making sure that I determine the strategy, not the lens, and I make sure the lens material comes to me in the middle, safe from the iris, safe from the posterior capsule, safe from the endothelium anteriorly. Slowly, it's gradually disintegrating, and still not being tempted into the periphery, staying in the middle. And at this stage, you can see the pieces now are willing to come, because the aspiration rate and the vacuum levels are just what I want it to be at this point. Final quadrant, bring it in with foot position 2 and holding it in with vacuum, then emulsifying, sub-chopping again to bring the last segments into the safe zone, and releasing it into the phaco probe. Staying very safe, keeping the second instrument at this stage. I like to keep the second instrument behind the phaco probe at this point to make sure that the posterior capsule doesn't surge forward, as it can do. But this device, it was just perfect. You can see now that posterior capsule is quite fibrotic, but I'm not going to do anything about that at this stage. And we then have a nice clean bag and a capsule that's open, and I deliver a 3-piece lens. I decided I'd use a 3-piece lens in this case, placed in the bag, and you can see it goes in quite readily. So just dialing it into position with a Lester Jones dialer, and it sits nice and centrally, and hopefully it's going to remain in place. So now I want to release the capsule, the pupil expander, and just releasing it from the superior pupil, and then back in with the introducer to remove it. And then remove the viscoelastic and clean up, and at the end the wound sealed quite nicely, and the surgery was over. So about 4 days later, this was the appearance of the eye, and everything was settling satisfactorily from the surgical point of view. But her acuity hadn't improved, but her vision had improved. She was pleased with the improvement in her vision, but her acuity hadn't improved. And when we did, at about 4 days, we did an OCT, we saw she'd got quite significant cystoid macular edema. Now, I believe this cystoid was present already. I don't think 4 days would be long enough for this to develop as a direct result of the surgery. So I think she had pre-existing ocular disease, including the cystoid macular edema. And then you can see there the posterior capsule fibrosis. She also produced some giant cells on the lens, but these were not significant, and the eye settled down very satisfactorily. So the incision there at 2 weeks, you can see, is clean and neat, and her acuity was 1 on the logmar, but she did judge that the surgery was a success. She now could navigate quite easily with that eye. And was backed up by a much better vision in the right eye, which we'd operated on previously. So the takeaway message is really, in a case like this, for even ordinary or easy cases, it's very important to have a strategy before you go into theatre. Know exactly it is what you want to do and make sure that that's what you achieve. So thank you for your attention.
Thank you very much, John, for this excellent presentation. And of course, these are very rare cases, I must say, very difficult cases. And in addition, I think that if you look at the transparency of the cornea, that cornea also presented a kind of primary haze, like it is typical in such cases. They do not only have a very opaque anterior capsule, but they also have often a quite stromal opacification of the cornea that doesn't help the surgeon to do the cataract surgery at all. But on the other hand, I think it is a marvelous presentation, and it is again a good explanation that you show us another way of using pupil expanders. I guess that you have used different kinds of pupil expanders, and that you chose and you finally use this one. Tell us a little bit more about this expander that is a little bit less popular, I think, or less used, but maybe that you can convince us to use that device as well.
I actually have very little occasion to use a pupil expander. If I have a small pupil, I prefer to do sphincterotomies. The reason I prefer sphincterotomies in the ordinary small pupil case is I feel it leaves the pupil, the iris, more anatomically and physiologically active. But in these cases, I've used other ones, and sometimes I find them a little bit hard on the endothelium, and because maybe something to do with the material from which they're made from. This one is very soft and very easy to manipulate, and I just like the way it goes in and out through the shooter. I'm not saying it's the best one. I'm not saying it's better than others or anything. It's just the one I chose for that particular case. And I have seen many that I haven't had an opportunity to look at. There are some now ones that are very, very thin, made of very thin material, and they're almost invisible when they're in situ during the surgery. And they're probably very good to use as well. But certainly, I prefer to use that type of device rather than just stretching this type of pupil. And as I say, when we took it out, the pupil obviously didn't revert to its natural size, but it was good enough. She didn't have any glare or any problems from the enlarged fixed pupil.
I like the idea of the radio frequency, and Cloete, of course, is a very good. Well, I have very good memories. I went to his place and I followed his surgeries and so on. Very brilliant ophthalmologist, I must say. But on the other hand, we are always dealing with those bubbles, just the same like you have with the femtosecond laser. And that is the reason why for example, I would prefer to use scissors, micro scissors, to cut those fibrotic tissues. So I would use another technique than you, but I understand your choice.
And I did have a scissors as part of my backup.
Yeah, okay, that's a good answer. But I think that is a little bit the idea of this presentation, is of course to show all the different options. But of course, the surgeon should know that there are different ways to solve the issue, just like Tobias showed us about centration. I think that's not a holy grail yet, because we still do not know how is the macula oriented or centered to the apex of the cornea. These are all different issues that are still unknown, I must say. And well, when I have to, I do not like bubbles. I like champagne, but not bubbles in the anterior segment of the eye, I would say.
we have a term when we get a lot of bubbles. We call it Faco Prosecco.
Okay, fine. So we are in the same line. Okay. Thank you very much. And now